Good morning, everyone, and welcome back to our monthly Intellectual Disabilities and Dementia Texas Echo. I'm joined this morning, I'm Catherine Pierce, COO of the NTG, and I'm joined by our hub team members, Dr. Kathleen Bishop and Dr. Lucy Ezralou. We are a small but mighty group this morning. Dr. Keller was just on, but he has had a medical emergency that he has to go take care of with one of his patients. So he dropped off. Dr. Jeter is on spring break today. And Dr. Sadowski had a conflict. So we're a small but mighty group today, but that's all right. Want to welcome you back again. This is our monthly ID and Dementia Texas Project Echo session, generously funded by the Texas Council on Developmental Disabilities. We are in year 5 of our 5-year project. And so after this month, we have 2 more echo sessions, one in April and one in May. And then that will be, sadly, the end of our Texas project, which I know Kathy Bishop and I are sad about because we have really come to love working with the folks in Texas these last 5 years. But it's been a great project, and I think we've made a difference. And so anyway, we're going to make the most out of the next echo sessions that we have. We're very excited today to have Dr. Lucy Ezralou doing a presentation for us on how do you use the NTG early detection screen for dementia to capture observations of change and how that really works in practice. Everyone is just a couple of housekeeping things, and then we'll go right to Lucy and let her get started with her presentation. We do not have a case presentation today, so Dr. Ezralou has the full time for her really very important presentation. So maybe that has worked out for the best. You are all muted by default. If you have questions, please put them in the Q&A box. If you have questions of a more technical nature, you can put those in the chat box. This is being recorded. We'll send the recording out after the fact, and we'll also include a PDF version of Dr. Ezralou's slides. She also has a couple of case studies going along with it, and we will include that information as well in the follow-up email. But we're glad you're all joining us today. And so with that, I think we will just jump right in and go to you, Dr. Ezralou, to start your presentation.
Well, thank you. Good morning to all of you. I am talking to you actually from the West Coast. So I am a little behind in the time of the day today. So it's my pleasure to be able to talk to you about the National Task Group Early Detection Screen for Dementia. And this is who I am. I'm a senior supervising psychologist for the California Department of Developmental Services and an NTG board member and co-chair of both Applied Research and Clinical Health Arch Group and the co-chair of the NTG advisory body. So let's look at some objectives for today's session. I'd like to help you understand the value of identifying a person's cognitive, behavioral, and functional baseline using the EDSD. And I'd like to provide some tips on how to complete this screening tool to capture your observations of change of the individuals that you're supporting, and apply the EDSD, the tool, to 2 brief case scenarios, and consider how to apply the findings from the EDSD to communicate within the team and inform decisions about services and care planning. So what is the early detection screen for dementia? The National Task Group Early Detection Screen for Dementia is an administrative screening tool. And you will hear me reference this several times today, and that is, it is not a clinical screening tool. In other words, on the basis of using this instrument, you are going to rate how a person is functioning, but it is not going to be the basis of diagnosing anybody with Alzheimer's disease or another neurocognitive disorder. Rather, it's going to provide some directions for the team as to where they can help the individual, either further investigating what might be driving some observed changes, or to give them supports that they may need in areas where supports are thinning. So what the tool can do is capture your observations of change, which reflect the significant departure from a person's typical functioning. And that information can be used to advance important conversations about change within your interdisciplinary or multidisciplinary teams, and also be used in your conversation with the individual's healthcare provider. Uh-oh. I just lost my screen.
Uh-oh. Let me know if you
Okay.
need me to put mine back up.
Yeah, would you? I don't know what happened. It just kind of went
Sure.
kablooey. Mhm.
All right, I'm going to stop yours and we'll swap it with mine.
It just like disappeared. Puff.
Magic.
Magic, not in a good way. All
All
right.
right, let me get yours here. Hang on. Do one more
I
thing
don't know.
here.
I have a new computer, laptop, and maybe, I don't know, maybe I have a cyber ghost. I'm not sure.
All right, I think this is the one you wanted.
Right. Go to the one before and let's see. Okay. So what are we using the tool for? We're using it to get a baseline of a person's behavior across domains of functioning that may be informative to us. And so one of the reasons baselining is so important for people we support is the tools that are used in the general population that can alert us to the possibility of dementia are really not normed for our folks. So they usually presume average intellectual functioning. So those tools that are used in the general population are often not helpful. What is helpful is understanding change from an individual's own typical behavior. That is what can alert us to the type of changes that we're wanting to notice and intervene, and when we want to intervene. So it can be used to capture observations of change and advance important conversations and inform decision making. Next slide, please. So it's a communication tool that aids decision making. Again, not a clinical tool. You would never diagnose somebody on the basis of the ratings by this tool. And it doesn't replace the need for a comprehensive assessment. In fact, it supports the need for a comprehensive assessment. There is no scoring or cutoffs used in the tool, at least as we are currently using it. And the person actually is in question is never directly assessed. So one of the things about a clinical assessment is you always directly assess the individual by giving them a task, by directly observing them. This is a rating tool, so it's an indirect measure and report on how somebody is doing. Next slide, please. So what was the rationale for the development of the EDSD? Well, we had heard early on in the formation of the National Task Group that family and professional caregivers needed some way to capture information that they had about changes in cognition, behavior, and daily functioning among people that they supported, and to be able to share these observations of change with healthcare practitioners. So, not only is that useful as a tool of communication within the team and also with the healthcare provider, it also is a way of training up caregivers, both staff and family caregivers, on recognizing important relevant signs of change. For those eligible, the EDST should be part of their annual wellness visit. In other words, if you reach a certain age, you have an annual wellness visit, and part of that is assessing cognition and functioning. And so information from the EDSD could be used as part or incorporated in that annual wellness visit. Next slide, please. So that's what it kind of looks like, just a couple of the pages of it, and so the EDSD can be completed by support staff, family, and other stakeholders to note the presence of key behaviors. And the items that are on the EDSD have been linked to the types of changes that we do observe in individuals who have Alzheimer's disease and other forms of neurocognitive disorder. Additionally, the form picks up on changes in health status. It picks up on activities of daily living, behavior, function, memory, and also has a section where an individual can have a rating on self-reported by the individual who is being rated, if they have reported changes in their own memory. And sometimes that happens where an individual say, I notice that I'm not remembering, or I'm having a hard time remembering, or something is different about how I can think or remember. The tool is available in multiple languages. We just got word that we have a translation in Japanese, but multiple languages, and you can obtain copies. So there are two forms of this online on the NTG site. One is something you can download, kind of a paper pencil type version, and the other is an electronic version that you can actually just type in the forms, the form, and the PDF form. Next slide, please. Okay, so who can use this screening tool? Any individual. You can use this for any individual to screen them with IDD, regardless of the cause of their intellectual and developmental disorder. And I'm saying that because people typically associate Down syndrome with dementia. However, we have reason to believe that other individuals who do not have Down syndrome might also be at risk. And so this tool is not a Down syndrome specific tool. It could be used for anybody with any type of intellectual developmental disorder. A person with Down syndrome, however, whom we know is at higher risk for early onset dementia, particularly Alzheimer's disease, we do recommend that baseline with this tool is done around between the ages of 35 and 40. Lately, the literature reflects that it's better to get the baseline closer to age 35 before any evidence of change. However, by age 40, it's recommended. And this represents a change from the recommendation that actually is printed on the form, which I think indicates the baseline beginning at age 40 for people with Down syndrome. A person with non-Down syndrome IDD, for instance, intellectual disability without Down syndrome, autism spectrum disorder, fetal alcohol spectrum disorder, epilepsy, cerebral palsy, etc. You could begin using this tool when they are around age 50, or when you have noted changes in the areas that we're going to be looking at. Next slide, please. So some tips for completing the EDSD. So who should complete it? Anyone who really is familiar with the individual. Again, this is an administrative tool. It's not a clinical tool. It does not presume, it does not require that anybody, has a clinical background. So whoever has everyday knowledge of the individual can do this. So, family member, staff, another stakeholder who is knowledgeable of the individual at least has at least 6 months experience with the person. And where it can be done anywhere. As I mentioned before, it's not a direct assessment. You do not even need the individual who you're rating there with you when you rate. So how you can get the tool is on the NTG site, which the link is in the slide that I had shown earlier. So when you go on to the NTG.org, you can find the EDSD in multiple languages that could be downloaded. And I said, or used, electronically, either as paper and pencil or electronically. So if the person goes to a day program, the staff there could fill this out. If a person lives in a supervised residence, the staff in the group home or supported living could fill this out. You might have multiple forms in which the staff at the day program and the staff at the residence, each complete in EDSD, and then the team gets together and kind of reconciles any discrepancy. A family member and staff could fill out separate forms, or they could fill out one together. So, it can be used in a variety of ways. The only thing you'll really need for completion of the form is to gather medical and other chart material, because some of the questions are pertinent to medical and mental health status changes that you might want to reference chart material in order to complete. Next slide, please. So, if possible, have the same rater fill out the EDSD every year or on a quarterly basis if necessary until the person has been referred and a diagnosis has been confirmed. Now, there are some people who've used the EDSD even after a person has been diagnosed with Alzheimer's or some form of neurocognitive disorder or dementia, as a way of just tracking departure from baseline. So I use it, and you'll see when we get to looking at David and Sarah cases that I have mocked up for our presentation, that I mark or highlight items which I'm unsure of. And I also use highlighters in order to kind of just capture my attention to areas where there might be change. You would share the ratings with your supervisor or designated staff for team review and summarize the findings for the individual's healthcare provider. Now, one of the things that is very important to know that you probably do not want to use this tool if the person is, for instance, in the midst of an acute behavioral psychiatric episode or has an acute medical crisis, because then the rating of that would probably be skewed by the immediate situation. Okay, next slide, please. So the importance of baseline information. So I mentioned this before, that really the best way for us right now to understand how to support individuals who have probable dementia or really highly suspect until they indeed have a diagnosis, is to notice and observe and capture those observations about what is different. How is their behavior and the activities, their cognition, their mood, how is it different than what is typical or we know to have been typical for the person? So when we measure baseline, we're identifying someone's usual or typical behaviors or functioning. Okay, and this helps us recognize when a person may be changing in their usual typical behaviors and skill sets. By identifying what is changing and what remains the same, we have a better idea of how to tailor services, care, and supports. Next slide, please. Now, of course, not all change from baseline is meaningful for our purposes. People may undergo as they age a number of changes that do not necessarily reflect the type of changes that are associated with dementia. However, the EDSD does highlight certain areas that raise the level of suspicion that the person might be having dementing changes. So the EDSD identifies domains important to the recognition of meaningful change in functioning that alert caregivers about the need to follow up. By bringing up to the team the topic of the client's change from usual functioning, and by bringing up to the client's healthcare provider changes from usual functioning, or by recognizing that more information is needed and additional tracking or investigation would be helpful. So maybe that you've noticed some beginning changes, you just don't have enough data or information yet about that for anybody to reach a conclusion about what it means. So that might be an indication just for the need for additional information about the person. Next slide, please. So, how can caregivers help professionals recognize early signs of dementia? Well, we tend to think about professionals as being the ones we look to, the doctor, the psychologist, the neurologist, the doctors, who are the ones who are going to answer the question about whether or not the person has a neurocognitive disorder like Alzheimer's disease or another type of dementia. And that is true. Professionals have expertise in the evaluation of neurocognitive disorders, at least some of professionals do. However, it's family members and staff who know the individual, and they are in the best position to notice important changes. Individuals with average typical cognitive development can be assessed using standard screens for dementia. As I said, there are a number of screens out there for the typical aging population. However, for the most part, these screens have not been normed with our population in mind. And so they're less informative for the people we support in terms of reflecting or understanding changes. Individuals with intellectual disability need to be assessed by recognizing significant change from their own baseline functioning. And this is how caregivers, both family members and professional caregivers, formal caregivers, are in the best position to assist in what will be the ultimate recognition of whether or not the person meets criteria for Alzheimer's disease or another type of dementia. Next slide, please. So, just kind of a brief recap. You know this, but I'm just going to raise this up in the context of our conversation. I use the term dementia, but dementia is not a diagnosis. It is an umbrella term. And under that umbrella term, there are a number of conditions. The most primary, frequently diagnosed type of dementia is Alzheimer's disease. But there are other, there's multi-infarct dementia, there's Lewy body, there's frontal temporal dementia, so there are any number of dementias or neurocognitive disorders that are specific diagnoses. Okay. So again, using the EDSD would not give you a specific diagnosis. It would just tell you that the person is changing, some observed change that may suggest the person meets criteria for one or the another type of dementia. And we are learning more about these other types of dementias. We know most about Alzheimer's disease, but there are other types of dementia that individuals we support may be diagnosed with. And there is also the possibility that they might have more than one type of dementia at the same time. So, but these all are conditions that are associated with cognitive, behavioral, and adaptive changes. So that's why they are all neurocognitive disorders, and we generally refer to them as dementia. Next slide, please. So sharing findings from the EDSD can advance important conversations. The interdisciplinary team can consider competing problems that need to be explored as possible explanations of the observed change. In addition to any of the forms of dementia that I mentioned, the following can be contributing to observed changes. The person may be depressed. The person may have a medical emergency that relates with linked to their being delirious. They may have sensory losses that impact on their functioning. They may have unaddressed pain that is affecting how they function. And they may be experiencing psychosocial stressors. All of these, or combination of these, amongst others, so this is not the definitive list, can impact upon the cognitive and behavioral functioning, adaptive functioning of an individual. And it is certainly possible that in addition to meeting criteria for a neurocognitive disorder, these other conditions are further exacerbating the problem and pulling down the individual's functioning. So the ability to identify any of the things that may be contributing to changes in the person's functioning is going to be helpful in supporting that individual. Next slide, please. So what do we track using the early detection screen for dementia? We follow changes in behavior that interfere with independent functioning and diminish the quality of life and get in the way of an individual's goals, such as independent living, work, and relationships. Or we follow those behaviors that may put the individual or others at risk in terms of safety, in terms of putting this individual at higher risk for loss of placement, whether it's residential or their day program or work placement. Next slide, please. So, what changes might you observe in adaptive skills? So, adaptive skills we think about as activities of daily living and instrumental activities of daily living, ADLs and IADLs. So, ADLs are, your daily basic skills: feeding, toileting, dressing, bathing, ability to attend to hygiene, all those on a daily basis are what we think about as activities of daily living. We think about instrumental activities of daily living as kind of the higher order skills that may involve some planning or sequencing of steps that are not necessarily our basic living skills, but have to do with the quality of how we kind of go about. So, using the telephone, shopping, preparing food, housekeeping, doing laundry, using transportation, handling one's medication, or handling finances. So there are a number of individuals whom we support who really have been challenged in their instrumental activities of daily living from the very beginning. So we might not see changes in this. So they may never have done their own laundry or have been responsible for housekeeping or handling their own medications or finances. However, we do have people we support who have had these skills, and we may notice changes in their ability to execute these activities that they previously had in their repertoire. Activities of daily living is what we all need to do. And again, we have individuals who've needed various levels of support with regards to it. So we have individuals who've never been able to self-toilet or self-bathe or feed themselves. However, we have many individuals whom we support who have been relatively independent or independent in these activities of daily living. So, we're noticing changes from where their skill set was in ADLs or IADLs and/or in terms of what their present functioning might be. Next slide, please. So you might see changes in balance and gait, ability to dress, feed, or speak. And sometimes we talk about issues called apraxia or dyspraxia, where daily activities that involve multiple steps in sequence become difficult for individuals as they may age into a neurocognitive disorder or dementia. They might see increased need for assistance with bathing and grooming, whereas previously the person had minimal need for assistance or maybe no need for assistance at all. We may see people who have increased difficulty handling money if this was previously a skill they had, or difficulty maintaining their own living space if that was something they previously did, or using devices such as a phone or a laptop or iPad if that was something that they previously had within their skill repertoire. Next slide, please. So, what changes might you observe in behavior? And behavior is another segment within the EDSD in which you're asked a number of items to rate the individual a number of items. So, you may see if a person, is suspected of having a dementia, increased impulsivity, such as hoarding, verbal and physical aggression. Now, notice I said increased impulsivity. They may have been impulsive previously, but this might involve an increase in what is observed. Increased reactivity to other people, where individuals are getting into arguments and having difficult interactions with others. And, that is what we might consider a reactivity to people that was not previously evident. Their social behavior might become mismatched with social situations. So, people may begin to behave in ways that are deemed kind of inappropriate or mismatched to what the social situation requires. Like, stripping in public. That would be something, and was for somebody who would never have, had that issue come up before. Increased restlessness and agitation. That might be a change in behavior you might observe. Next slide, please. So, what might you observe in terms of cognition? Now, we think of neurocognitive disorders as all about how a person thinks and remembers. But I want to point out to you that these neurocognitive disorders impact all areas of functioning. And so we kind of purposely embedded it a little later in the EDSD. Want to make sure people pay attention to these other areas that you don't normally think about as related to cognition. But, certainly we do see changes in learning and memory and thinking. However, a lot of the individuals we support with intellectual and developmental disorders had issues to begin with. That's the nature of their intellectual and developmental disorder. But additionally, we may come to find they have memory changes that interfere with their productivity at work or doing chores at home, things that were easily within their repertoire before, or certainly within their repertoire before, which they're having increasing difficulty following through on. That may be increasingly difficult for them to maintain focused attention. Person may become even more highly distractible than they were before, or maybe before they weren't distractible and now they are distractible. And difficulty adapting to change. We do know that there are people who kind of get stuck and have different difficulty with transitions. I'm not talking about that. I'm talking about people who previously were able to negotiate changes and were flexible enough, didn't necessarily get stuck when they were transitioning, who now are having difficulty with adapting to change. And language skills. So obviously we're talking about people who have language skills or have had language skills. And one of the things we know about neurocognitive disorders like Alzheimer's disease is that you indeed may become impoverished, in your speech, so that you lose words, you lose the ability to communicate in the way that you previously did. So these are some changes you might observe related to cognition. Next slide, please. So your role as a rater, if you are rating using the EDSD, is to assemble medical and background information. So you have that at your disposal before completing the form. And if you're a staff person, it would be a good idea to confer with family or other direct care staff before completing the form. And consider the areas in which the individual has shown change. Consider the areas in which the person has remained the same. And you can place remarks in the last page on 6. There's a comment section to add important information in addition to what you have endorsed on your item ratings, because you may observe something that we did not capture in the items that are on the rating tool, but you think is important as a way of showing change for this individual that needs to be better understood. Next slide, please. So the tool, and we're going to have a chance to look at the tool more directly in a few minutes. There are different blocks of items. So you'll see activities of daily living, language and communication, sleep and wake changes, ambulation. Those are among the blocks of items that, or domains that are you're asked about on page 3. And you'll notice there are 4 choices. And the 4 choices really kind of constitute a Likert type rating scale. On the far left, you see always been the case. If it's always been a case that a person has had problems in this area, well, that's not evidence of change. That's just kind of basically saying the person has had challenges all along. If the person has been challenged in these areas, but it's gotten worse. So for instance, maybe previously you needed to provide verbal prompts, and now you need to provide hand over hand assistance in something. That indicates the person was previously challenged and need assistance, but the level of support that you need to provide has increased. And so you would check off with that item under that column. A new symptom in the past year is exactly that. Basically, you become aware of something within this past year that was not the case as a problem for the person and does not apply. The person doesn't have an issue in this area. They may be independent. It's just not an issue. So the outside 2 columns are not as informative as the middle 2 columns. Those are the columns in which information about change is contained. Next slide, please. So as I mentioned, it's a Likert style rating. It's composed of a series of, and you've all done Likert ratings before. It's a series of 4 or more items that represent a range of choices for the same question or item. So again, for the EDSD on pages 3 and 4 of the 6 pages, you're going to be asked, has always been the same, has always been the same, but worse, is a new symptom, or does not apply. So that's the range of choices. The columns that are most informative about change, as I said, are new symptoms and always but worse. The columns always the case and does not apply are areas in which there's no reported observed change. However, that's also informative to know that the person has not changed in these areas. So let's consider what each one of these tells us as a way of capturing observations of change. Next one, please. What do we mean by always the case? Well, Keenan has always needed help bathing. It has always been the case that he does not initiate conversations. He always sleeps excessive amounts of time during the day. So, by choosing always been the case for the person you're doing the rating for, you're indicating this is usual and typical for the person. There has been no observed change in this area. Next slide. Always the case, but worse. Rose has needed verbal prompts to complete showering, and now she needs hand over hand assistance. Rose has mobility problems. She previously used a walker and now needs a wheelchair for anything further than short distances. She previously needed her food cut up for her, but now she can only eat finger food. Okay, so by choosing always been the case, but worse, you're indicating the person has lost more skills and is less independent with an activity of daily living for which she had already had problems. The person is having increased difficulty in an area for which she was previously challenged. So that is a change that is worth noticing. Next slide. New symptom. Walt has episodes of incontinence, which began 3 months ago. Walt has become lost while walking home from his program twice within the past 6 months. Walt cannot remember the names of new staff members and is calling them by the names of workers who've not been at the home for several years. By choosing new symptom, you're indicating for the person you're rating that this was not previously a problem, but is a problem now that you have observed. And it may be an important sign of change that we want to track. Next slide, please. Does not apply. Joy does not need assistance in showering. She does not need assistance in dressing. Joy may have episodes of mild forgetfulness, but this does not interfere with her work or daily activities. By choosing does not apply for the person you're doing the rating for, you're indicating this is an area in which, in this case, Joy does not have a problem. So there's no issue there. And that is good information, but it's not information about change. Next slide, please. So we're going to have an opportunity to meet David and Sarah. Both are individuals with intellectual and developmental disabilities. They have different patterns of strengths, challenges, and preferences with different support and services needs. Staff who are familiar with each of them have observed changes. The staff want to capture their observation of change by completing the NTG-EDSD and sharing their findings from the tool with their teams. And I think at this point, Catherine, we can open up uh, the um, uh, the PDF for David.
Okay. Get that up right now. Bear with me just a second.
That's okay. Catherine
Sarah.
is doing this because my system is completely bombed out on being able to share from my. So
I gotta just get to the
thank you for your
David
patience.
one here. Got Sarah, but let me get to David here. Okay.
Yeah, we'll get to Sarah in a little while.
Hold on one second. There we go. No, that still says Sarah. Well, we're gonna do it this way.
I did send
I
you
think I can.
David.
Yes, I do have it. I think. Let me. This is. There he is.
Yeah, okay. All right,
Can you
there he
see him? All
is.
right. Yep.
Yeah. All right. So one of the things I want to just point out a couple of things about this. So this is the EDSD, the tool, and you'll see in the block it has a little bit of information about the early detection screen for dementia. The estimated time for completion of the form is about 15 minutes to 60 minutes. It really, for somebody who knows the individual, should not take up to an hour, but could. And then, of course, you want to draw information from the individual's medical record. So the first page contains some information, demographic information, and so we've named this is a mock form. It's not the form of anyone in particular. And so it's the form for David Smith. He's 62. He has mild intellectual disability. Can we move it a little? Thank you. So you'll notice that I have put, I'm using yellow and green highlighters, and that's my personal, you don't have to use any highlighters. You can use different colors, but this is what signals to me. For green, I will often use a green highlighter to just indicate these are more stable kind of chronic or long-standing issues for the individual. So we know David has Down syndrome and intellectual disability, that he lives alone in a community, situation. He lives in his own apartment and it has support staff. Next, could you kind of move it down yeah. So page 2 asks you as the rater to make some kind of overall ratings about current physical health. So his current physical health is fair. It is somewhat worse than last year, according to the staff who completed this. And that's why I used a yellow highlighter to just kind of say, oh, this is something I'd be a little curious about. I'm going to ask staff, what do they mean by his health being a little worse? And they said that his mental health compared to a year ago is somewhat worse. So that's another thing I'm going to be very inquisitive about. He does have some sensory issues, both vision, which is corrected by glasses, and hearing corrected by hearing aid. He has no history of seizures. And interestingly enough, and this is highly unusual, in 2016, he was diagnosed with mild cognitive impairment. That is not typically a diagnosis that we see among individuals with intellectual and developmental disorder, but what it indicates is there was an observed change in at least one area of cognitive functioning. We'll say it was a change in his ability to pay attention, focused attention, but he did not meet criteria for diagnosis of a neurocognitive disorder. And it was a psychologist who decided that he had mild cognitive impairment. Can we go further down? Yeah. So in May of 2016, the MCI was based on, there is a SIB, I know means self-injurious behavior, but actually it is a battery, a psychological battery called the severe impairment battery. So the severe impairment battery was used to reach this MCI diagnosis, and also in terms of observation and collateral report. Let's go to page 3, if we might. So,
Lucy, can I stop you for a second? You have a question that actually came in a few minutes ago. Might be
what
better
is
to
that?
answer it.
Yeah.
In people with Down syndrome, at what age do these SSX start manifesting?
Well, I mean, what we want to, probably begin baselining individuals around age 35, from 35 to 40. And very often you begin to see these symptoms after 40. The most common period of time to see changes associated with Alzheimer's disease and other neurocognitive disorders is in the person's 50s. I think the average age is around 52. However, very often people are reporting changes in the person's 40s. So that's why we're kind of recommending baseline, use this the first time when the person is somewhere between 35 and 40.
And Lucy, I want to add a question of my own because I'm frequently asked, can we use this sooner than the recommended age?
So I wouldn't necessarily use it earlier than 35, and that's because we do know, for instance, for individuals with Down syndrome, there is a regression syndrome that is possible for people in their 20s, or more likely in their 20s. And this tool is not meant to pick that up. And that's a different process. So there's really not a reason to believe that you would use it before age 35 for somebody with Down syndrome, and for somebody without Down syndrome, probably don't need to use it until a person's around age 50.
Great. Thank you, Lucy. That helps clarify for me as well. So thank you.
Sure. And so you'll notice for David, there are a lot of does not apply. So he's still pretty independent in a number of ways. However, he's been incontinent. He's had some urinary accidents, and that might be something I highlighted it in yellow to better understand. He's having problems with finding words, something that we call anomia, and appears to get lost in the middle of conversations. And we've noticed a number of things with sleep and wake pattern: inadequate sleep, wakes frequently at night, confused at night, wanders at night. Ambulation remains pretty unaffected. Can we move this further? However, he has had some falls. Okay, so he's confident in walking, and there have been some falls noted. So I have it in yellow because I would want to inquire from staff or family. Okay, tell me a little bit more about this. What was the context in which, was he in a familiar environment? Was he outdoors? Was it in, what's going on with that? Can we go further on to page 4? Okay, so here we got, a number of changes in memory. So he does not remember recent events in the past week or less. Want to find out more about that, about his losing or misplacing objects. However, he loses track of time. That has always been the case, but it's somewhat worse. So I'd like to hear, in what way has it gotten worse? He has begun wandering. That's usually a sign that we really want to follow. Withdraws from social activities. He was previously pretty social, and now he's withdrawn. He seems to go into his own world. That's always been the case, but worse. And obsesses or has repetitive behaviors. That's always been the case, but worse. Increased impulsivity. Want to find out more about that. And he appears depressed. Want to find out more about that. And he reports there's changes in his ability to do things and changes in his memory. And that's something that he has recently reported to staff. And so we also are saying that there was a change in gait, indicated by the previous item where they said that he fell. That's relatively new. Next page, please. So here we have an interesting addition from the University of Chicago, University of Illinois, Chicago, having to do with longitudinal medical issues. So one of the things we're interested in tracking is, are there chronic health issues or kind of more recent health issues that seem to be associated with changes that we might associate with dementia or probable dementia? We see he has high cholesterol and high blood pressure that has been relatively recently diagnosed. Thyroid disorder has been a lifelong condition, which is not unusual for people with Down syndrome. Depression has been recently diagnosed, and I'd want to know more about that. Just because it was recently diagnosed doesn't mean that it might not have been the situation for him for some time. He does have impaired hearing that was diagnosed within the past 5 years. Now, again, it's not unusual for males as they age to with Down syndrome have hearing loss, and impaired vision that has been a pretty much lifelong condition. Okay, can we continue moving down? Okay, so and then we noted that he has had episodes of urinary incontinence. So the last page, page 6 of the EDSD, just asks about current medications. That's why you need the medical chart or information from the medical chart. You're getting a treatment for any chronic conditions, treatment for any mental health or behavioral problems, treatment for pain. So yes, treatment for medical conditions, yes for mental health or behavioral problems, no for treatment of pain. And there was a list of medications that were attached to this or would be attached to this. And the next steps are refer to treating physician for assessment, include information in this person's annual review, and repeat every 6 months. So one of the questions I sometimes get is how often should you do this? So I would say you do it on a yearly basis until you begin to observe signs of change. When you begin to observe signs of change, you might want to step it up to every 6 months. And in some cases, you might want to do it, on a quarterly basis. But generally, I would say 6 months if you've begun seeing signs of change. Okay, so can we go back to the PowerPoint, please, Catherine?
Sure. We go back to that.
Right, easier said than done.
No, we get it. We'll get it. Go.
Okay, so next slide, please. And that's David. Okay, so now let's go back. You can go the previous one. So you saw the cover page, and it's used to provide information about the person being rated. Next page. Next slide. So again, he's 62 years old with mild intellectual disability and Down syndrome. So what are some of the things, the information on the cover sheet that might alert us for something for consideration? Well, one of the things to think about as you proceed in rating David is that he's at higher risk for Alzheimer's type dementia, just on the basis of his age and the fact that he has Down syndrome. That's not a slam dunk, but it certainly will raise our level of suspicion to be looking for things. Next slide, please. And in the opinion of the rater on page 2, how's the person's current physical and mental health? So we saw how the staff completed it. And then we also saw for items 16 to 18, there was something for mild cognitive impairment. So that's, really takes care of page 2, getting an overall snapshot on where the person is now relative to perhaps last year, and if there is any previous diagnoses. Next page, next slide rather. So although the raters indicated David's health is good, they also indicated it's worse than last year. They indicated he appears sadder or more anxious when asked, in terms of mental health. Staff rated him as somewhat worse in his mental health compared with last year. We know that David has some sensory issues. He wears eyeglasses and hearing aids. And in the past year, David experienced several stressors. A family member died, and his favorite staff left during COVID and did not return. David was diagnosed, and this is somebody with whom he had worked for a number of years. David was diagnosed with mild cognitive impairment 2016 based on lessened productivity at work, less interest in keeping up with chores at home, lessened interest in socializing with others, and a score on the severe impairment battery. Next slide, please. So, again, pages 3 and 4 are going to look at these domains: activities of daily living, language and communication, sleep wake cycle, ambulation, memory, behavior and affect, adults' self-reported problems, and notable significant changes observed by others. Now, just going up to activities of daily living, there is not as much about instrumental activities of daily living. So if this is somebody you're rating who has been higher functioning and you're noticing a change in their ability to handle money or to handle, their, computer or the electronic devices, their phone or whatever, that might be something you would comment on in the comment section. Next slide, please. And again, with this, you have the Likert choices, always been the case, always but worse. New symptom does not apply. Next slide, please. So what did we learn from page 3 for David? Well, we learned that David's pretty independent in many activities of daily living. We know this because his staff has checked off the column does not apply for several items. He has been exhibiting a relatively new symptom of urinary incontinence. And that can mean a variety of things. It doesn't necessarily mean that he has dementia, but it's certainly something we want to learn more about. Under language and communication, which was the item block 20, he's displayed new signs of change in his communication skills in the form of word finding difficulties. That is notable. And he tends to lose track in the middle of conversations. Those are changes in his communication behavior, and those are notable signs of change. Next slide, please. In terms of sleep, several changes were reported under new symptoms. He's sleeping less compared with before. He is waking frequently. When he's awake, he appears confused. Staff have reported several episodes of middle of night wandering from his home. So again, these are important changes to take note of and to learn more about. Again, just because you score on that, you are rated on that item and endorsed on that item doesn't not mean definitively that the explanation for that is that the person has dementia. And staff has endorsed in the ambulation item 22 that gait issues have been a little more challenging. He's fallen twice during this period of time, but without injury. And again, would want to find out more about that. Next slide, please. So on page 4, under memory, we find out there were a number of changes. He does not remember recent events in the past week or less. He does not find his way in a familiar surrounding, very significant. He loses track of time, although that has always been an issue for him. It's gotten worse, like not able to track time of day, day of week, seasons. He loses or misplaces objects, and he has problem with learning new tasks or names of new people. Calling new staff by the name of staff that have left a long time ago. In terms of that block of items that go correspond to 24, behavior and affect, he's wandering. He shows signs of increased impulsivity. He appears depressed. He withdraws from social activities and seems to go into his own world. He is exhibiting obsessive or repetitive behaviors. So again, these could be accounted for by other things. So, it's not enough to just kind of get rated in this area as this is a change that's observed. We want to be curious. So what's going on that might explain why there's an increase in impulsivity or changes in the behavior where there has been reported change? Next slide, please. So, we did find out that he himself is saying, the changes in my ability to do things. I'm not doing things as well. And he's been able to say that he notices his own changes in memory. And others have, again, been commenting upon the falling. And, so I don't know if he's a fall risk, if there's something in the environment that needs to be checked out and changed, or something about his vision, depth perception. There are any number of things that may contribute to falling as a person ages with Down syndrome. Next slide, please. So on page 5, we see that, we have some choices. Is it a recent condition within the past year? Has it been diagnosed in the past 5 years? Is it a lifelong condition, or the condition is not present? Next slide, please. So David's medical conditions include high cholesterol, hypertension, thyroid problems, depression, sensory issues such as hearing and vision impairment, and urinary incontinence. For possible further consideration, the team might want to be looking at his high cholesterol and hypertension, which put him at higher risk for stroke, cardiac problems, and associated cognitive change. Might want to look at the possible connection between his lifelong thyroid problems and any mood issues. And of course, he's been diagnosed recently with depression, and that can contribute to problems with concentration and attention and memory. His episodes of incontinence may be due to a urinary tract or prostate problem. Also, he may be misjudging when he needs to use the toilet. So, what is it that's contributing to this urinary incontinence? Is it a medical condition that can be addressed, or is it something having to do with his toileting skills? Next slide, please. And page 6, we want to gather information for the person's chart regarding current medication, dosage, and when prescribed. We want to get any background information relevant to give us context to this rating. And as I noted, other changes observed but not covered in the rating form. It's your opportunity to share what you've observed and also consider what next steps the team wants to take with this individual. Next slide. So with David, staff began with questions about observed changes in David's cognitive, behavioral, and adaptive functioning. Ratings revealed several long-standing problems that need to be monitored and several new symptoms that needed to be investigated for their possible role in his observed decline, including the possibility of sleep apnea, which is a high occurrence phenomenon among individuals with Down syndrome. David should be reviewed again in 6 months unless there's signs of change that he's worsening or he receives a diagnosis of a dementia. Next slide. So we're not going to get a chance to look at Sarah's form, but I just want to highlight some things about Sarah. And one of them is that, to cut to the chase, she is somebody who has a history of a significant mental health issue. She's 57, has moderate intellectual disability, and lives with relatives in her family home in the community. And what are some things to consider about her diagnosis of bipolar disorder? She does not have Down syndrome, but or to consider about her, but her level of intellectual disability, moderate ID, and history of significant mental illness, bipolar disorder, may be factors in observed decline. Next slide, please. Sarah's relatives and staff rated her as currently having fair health, which is worse compared to last year. Sarah's mental health is about the same. We know that she's diagnosed with bipolar disorder. And by the way, bipolar disorder is a chronic condition. People tend to be diagnosed with it fairly early in life. It is persistent, and very often they have been on medications for bipolar disorder for multiple decades. She wears glasses. She's had 2 stressful episodes, including reacting to change in her medication for bipolar disorder. And she has become overly sleepy, drooling, and confused during this medication change. She had a conflict with her sister and with staff. In the comments section, staff noted they've observed a change in several areas of her functioning. Next slide, please. What do we learn about Sarah from her ratings on page 3 and 4? And by the way, I did supply Catherine with a PDF for Sarah and David, so that could be among the handouts that you would get and have a chance to look at Sarah's PDF. And again, Sarah's not an actual individual. This is a mock scenario. Sarah may undress in public. She has word-finding problems. She does not follow instructions. Sarah sleeps later than usual, and she does not remember the names of familiar people. She has obsessive or repetitive behavior, hides or hoard objects, increased impulsivity, touching others, arguing, taking things. She appears depressed. She shows verbal aggression, and she displays physical aggression, temper tantrums, uncontrollable crying and shouting. So I want to point out several of these things look familiar to what David displayed, but the point we're driving home here is actually Sarah has a very different source for these changes that have been observed that are not the same as David's reason for changes. Next slide, please. What do we learn about Sarah from page 5? She has arthritis, cardiac disease, bipolar disorder, diabetes, and gastrointestinal problems. So she has quite a few conditions that are kind of impacting her on a variety of levels. Next slide, please. Although she had two potential sources of pain, arthritis and gastrointestinal problems, she's not on any pain management regimen. So this is something for the team to consider. She's diagnosed with bipolar disorder, for which she's receiving medical management. It might be worthwhile for the team to better understand the status of her cyclic mood disorder. Bipolar disorder is a cyclic mood disorder. When was she diagnosed? When was she initially treated? It could mean that she's been on the same medications or similar medications for multiple decades. And is that driving any of the observed changes? Has her medication been recently reviewed? What are some of the non-medical ways she may be receiving supports for her bipolar disorder? And the answer was actually she's not receiving any non-medical support. So that's something for the team to better understand and investigate. Next slide, please. So what do we do with the ratings from the EDSD that we get from David, from Sarah, from anybody we rate? We ask questions to clarify the ratings or comments so we better understand what the rater is observing. We look for any patterns. What are the areas in which change has been noted? What is the extent of change? Is something being done to currently address identified issues? Or, what are some of the pathways that we could further investigate or address these issues of change? And we want to bring the findings from the EDSD, of course, to the team and ultimately to the healthcare provider. Next slide, please. So I want to share, the findings with members of the team and reconcile any discrepancies across settings. So if one form was completed at the day program, one form in the residence, and they seem to have different findings, we want to reconcile that discrepancy and request additional information if necessary, brainstorming possible approaches leading to us operationalize a plan of action. Is it time to refer the person to their healthcare provider or other professionals? And we want to evaluate the effectiveness of ... whatever plan we have come up with. Next slide, please. So what are some of the types of decisions that may follow from the use of the EDSD? We might lead to some thinking about modifications in the person's residence. Maybe they need to change their residence. Maybe there need to be changes in the level of staffing support or the type of programming that is done with the person. Maybe developing a positive daily routine might begin to look a little differently as they need additional supports. And items and activities for stimulation. I don't know why things dropped off here. That may indeed be, we have to look at what resources we might need to bring in to support the person's changes so that they can remain active and engaged as long as possible and as long as they choose to. Next slide. So what are next steps for David and Sarah? Well, what patterns did we find in their ratings? How can we use the findings from the EDSD to plan supports and services? Next slide, please. Since David is at higher risk for Alzheimer's due to his age and Down syndrome and his previous diagnosis in 2016 of mild cognitive impairment, the IDT wants to refer him to his healthcare provider for further workup. The team may want to explore how sensory changes, both hearing and vision, impact upon David's functioning. They want to explore if he's a candidate for balance and gait training to prevent further falls. My depth perception have contributed to hit, so typically as individuals age with Down syndrome, many develop depth perception problems, which could contribute to falling. Or is there some changes in the environment that are needed in order to make sure that David can more safely ambulate within the environment? The team will speak with David's healthcare provider about a possible sleep study to rule out sleep apnea. And staff will consider helping David develop a positive daily routine by providing him with choices within a scheduled and structured day. Next slide. How can the IDT use the information from the EDSD rating to best support Sarah? Sarah may be displaying cognitive, behavioral, and adaptive changes related to her history of bipolar disorder. So I'm suggesting to you, she does not appear to have Alzheimer's type dementia, or, her presentation, although there are points that looks to overlap with David's, it's actually driven by a very different process. Since it appears that her functional abilities vary when she's depressed or manic, the IDT may want to track variation in mood as they relate to her functioning. So when she's depressed, she tends not to engage in activities of daily living. And when she's manic, she tends to kind of overdo things. And so mood directly impacts upon her functional level. Staff may refer Sarah for pain management to see if pain discomfort from arthritis or gastrointestinal issues may be contributing to observed changes. And the staff will consider her support needs as they may vary according to her mental health status. Sarah's family and team may want to explore whether she has adequate medication and non-medical treatment for her severe mental illness, which bipolar disorder is considered a severe mental illness. Next slide, please. How might the use of the EDSD lead to a diagnosis of neurocognitive disorder? Well, it's by ruling out other factors. The healthcare provider may recommend further testing and evaluation that can target whether or not the individual's observed changes are due to a dementing process. Although the EDSD is not a diagnostic tool, the review of the findings may result in a referral for further diagnostic workup that can confirm or disconfirm the probability or likelihood of dementia for the person. Next slide, please. So considerations for the use of the EDSD. Again, this tool is not used for the diagnosis of dementia. It's an administrative and not a clinical rating tool. It's a tool used to support decision-making. The diagnosis of neurocognitive disorder involves a medical exam, direct cognitive and adaptive testing of the individual in question, lab workups, etc. If the consumer is already known to have a neurocognitive disorder like Alzheimer's disease or vascular dementia, you can still use the rating form to baseline observations of change over time. Since this is an early screening tool, it's not necessary, of course, to continue using it if the person has been formally diagnosed with a neurocognitive disorder. So you could choose to use it, as some agencies have chosen to continue using it. But the whole purpose of this was to capture early signs of change that might indicate the need for further conversation or investigation, leading to possible diagnosis of dementia. Next slide, please. So what are the take-home messages? So family and staff are in the best position to recognize everyday changes in memory, thinking, behavior skills, and activities of daily living for the people whom they know and support. The EDSD is an administrative screening tool that can be used to capture information about observed changes in functioning of individuals with intellectual and developmental disorder. Finding from this tool can aid and promote healthcare advocacy. Findings can be shared with members of the interdisciplinary team and healthcare providers to make decisions about services, supports, and treatments. And that's it. So what are your questions?
Let's see here what we've got. Whoops, let me just, I think.
Yeah, there is one in the
Okay,
Q&A.
that's not the one you had answered, you had
No, this
done
is a new one.
before. Okay, you want to do it,
Okay.
Kathy, or?
Sure, I'll be happy to. The question comes in from Kim. Summit DD, I assume you're in New York, and I welcome, close neighbor. I am wondering if it makes sense to assess someone without a Down syndrome diagnosis earlier than 50 that has been identified as having multiple risk factors: trauma, polypharmacy, mental health diagnoses, family history, cardiac issues, TBI, etc. The person I'm thinking of has all of these things in his history and very minimal ability to communicate and would have no ability to self-report. We would be very reliant on an accurate baseline. Sorry, I realized Summit is in Texas, so we do have a Summit area in New York as well. Did that make sense, Lucy?
It did. I mean, so you're talking about a incredibly complex history for an individual who does not have Down syndrome, but has multiple other possible drivers of decline or functional change. So you're absolutely right in kind of capturing a baseline. So the thing about the screening tool is it's really kind of keyed to those areas where you're going to see change if somebody has a dementia. There are other adaptive behavior tools. So there are other ways to baseline information. So the answer is yes, baseline information about this individual who is younger than age 50 and does not have Down syndrome, but has mental health issues, has a trauma history, and that kind of a thing, multiple things going on, is minimally nonverbal or minimally verbal, so that you cannot get subjective report from them. So, I would look for a tool. I wouldn't necessarily look to the EDSD. I would look for a tool that can, like the Adaptive Behavior Assessment Scale or the Vineland or any of the adaptive behavior tools, where you can do a broad baseline of where they are. And these are rating tools. So it's dependent upon a rater who has knowledge of the individual, family, and or staff who would be doing the rater. So, so that's kind of, because I'd be surprised. Now, again, if you have a trauma history, you are at higher risk for developing a dementia as you age. So I'm not saying that the person is not at risk but I'd first want to just get a good general baseline that is not necessarily tied to or anchored in the items that are at the EDSD. Right. I mean, does that make sense?
It does. Lucy, would you just chat for a minute? Because I think this is an important aspect of functional change. The last page of the EDSD asked to attach a list of people's medications. And of course, as we know, people with ID oftentimes are taking multiple medications, and many have for many, many years. Could you just very briefly, decades, could you just briefly touch on the importance of those medication reviews in the context of cognitive change as one of those sometimes other factors, that it's not the onset of Alzheimer's, but might be medication related? I always like to reinforce that because I think it's so prevalent.
Yeah, it is very, so one of the things, and just to pick up on what you're saying, I've often seen people who are on the same medication regimen for decades without having these necessarily reviewed for efficacy. So the whole kind of thinking in, and I'm not a medical doctor, but certainly work alongside medical doctors with this, is to have the lowest dose of the most effective medication you can. So what happens is people inherit diagnoses and they inherit medications that follow them without people being curious. Okay, when's the last time we reviewed these medications? Is it possible that there is a cognitive dulling effect of some of these medications? Is a person having an adverse response to the medications? So very often when somebody's not responding to medication, the reaction is to add more medication. So the problem is not that the medication might not be the right medication, but we need more of it, and without really being curious about, is this an effective approach for this individual and what are the side effects? So every medication that is powerful enough to be helpful, this is certainly true for psychoactive medications. We have some wonderful psychoactive medications. However, they all have side effects, and that must be considered. Aspirin can have side effects too. So the fact of the matter, if it's powerful enough to be effective, it is powerful enough to cause side effects in some individuals. And for the team, knowing what those side effects are can help kind of parse out, okay, what are we really looking at here? When did we begin to observe that there were changes? So yes, so the list of medications make a big difference. The fact that for, that I mentioned for Sarah, the mock case of Sarah, that she had unaddressed pain. She has arthritis. She has gastrointestinal
Huge issue.
problems. Is a huge issue. Sensory issues, huge issue. How much of David's falling has to do with the fact that he has depth perception problems or other kinds of visual issues that he's not
or
able to
even pain if he's got some arthritis or osteoporosis and he's compensating, and that's making him unsteady. Yeah.
Right. So these are multiple. So part of the thing about the EDSD that I like the most is it asks teams to be curious. Let's be curious. What else might be going on? And it may be dementia, but what else might be going on in addition to the dementia, right? That can explain adaptive.
It should never ever be that jumping right to dementia to rule out by the healthcare provider or those that are recommending they need a healthcare appointment to rule out. They should be looking to rule out those pre-existing conditions. I also find gastrointestinal, especially the older person gets, seems to be ignored in terms of addressing, and even those medications have side effects as well.
Absolutely, they do. There is a question about, is there a list of practitioners maintained anywhere, noting who has training on using this tool. So you have training using this tool right now, okay? So it is not necessary for you to go to a practitioner. Now, if you want a practitioner to use the tool or to incorporate findings from the tool, that's another story. And I don't have a list of, Texas-based practitioners. But the point is, this is not a clinical tool. It does not require that a practitioner. You can use this rating. Once you become familiar with this idea of Likert scale and how do you endorse or not, and if any, you use your observations as the basis of rating the individual. And that is the information the practitioner can use to kind of tailor, okay, we're going to go in this direction. This needs to be further investigated, or that needs to be.
So they print the tool out and take it to the medical appointment with them if that's the path they decide they need to go.
I would highlight the findings. I would say, this is where we've observed change. this is, we haven't seen any change in these other things, but these are the things that concern us that we're curious about.
Even if the practitioner isn't familiar with it, it's a very visual tool and they can quickly look at it and see, oh, these are the areas of concern. And it saves them time from having to ask a whole bunch of questions because it's kind of all right there in front of them.
Yeah, and family members can do this. Staff can do. In fact, I wish more family members utilized it. I mean, I think it could be very helpful to the family supporting their relative, and I think it could be very helpful to the teams that are supporting somebody who lives with their family.
Yeah,
So,
I mean, that's the beauty of the tool. Family members can do it and then
right.
use it to inform their appointment with the physician. Yeah. I need to end it here because we're at 1 minute past the hour, but thank you so much for a great and I think highly useful presentation. Next month, I believe, Kathy Bishop, you are our presenter next month. Do you want to just tell people quickly what your topic will be?
Women deal with medications, therapies, treatments, women in the general population. I had been asked by another organization to provide a webinar, which I will be in a few weeks, specifically on women with IDD. And so I'm going to summarize that of some of the precautions, exactly like medications. In particular, women with IDD should be getting lower amounts, and there may be medications, including aspirin, is more dangerous for women with Down syndrome. And so it will be an overview of that. So I'm hoping everyone will come on and you will invite other Texans to come on, as we're getting down to there will only be two left,
Right.
that and this one and the other. I also wanted to add, I know we're probably losing people, but those of you who have been attending these, would you please send information and email to Catherine, I think, or myself? We'd really like to know if you could provide a little overview of a case or someone in your life, or as a result of attending these echoes, if you could give us an example of a positive effect that it has for you. We'd love to have that on record to include in our report that needs to go out, our final report.
I just put my email in the chat box.
Perfect. Thank you. We'd really appreciate and value that, and may encourage the opportunity to have future echoes, we hope.
So the next one will be April 15th, Wednesday, April 15th, 10:30 Central Time, 9:30 Mountain Time, and we'll send that out in advance to you with the link, but it's the same link we use every month. So if you had it for this month, same for next month. Thanks, everybody. And you're going to get a little pop-up survey for our funder TCDD when I close this down. If you would just take a moment to complete that survey, we would be very grateful for it, as would they. So thank you all, and we look forward to seeing you next month. Have a great 30 days. Thanks, everyone. Bye-bye.